talking about, and that's how I approach it. So it's not as intimidating when you think about it that way. So the topic that we'll speak about today is the residence educator. I have one idea to share with you that I think is pretty neat. I have 6 areas of evidence that I want to cover, and a handful of tips along the way. So I don't have any disclosures of conflict of interest or commitment. The only bias that I think I wanted to share up front is this quote that I think is pretty neat. In our teaching and learning roles, especially in the environment that you guys are in as teachers and learners, it's a complex situation. And finding time to teach is to adapt to the given situation where you can teach at any given moment where it's appropriate is quite a skill, and one that I'm sure many of you have mastered. So hopefully by the end of our session today, you will be able to somewhat competently achieve these objectives here. We'll talk a little bit about the rationale, not a lot, but just a little bit about midway through on the rationale for why this is important. Hopefully you'll hear some evidence that you can translate, and the tips are related to the evidence, so some practical steps of things you can do. All right, so here's my one idea. The idea is this: education should be evidence-based. And a number of people have talked about this. This is articles from 1999. It's really not a new idea. And it tracks right along with evidence-based medicine. The ideas are really quite the same. So in your daily worlds, you follow clinical practice guidelines and evidence-based care. And what happens when you don't do that? Anybody? What happens when you don't do that?
You spend a lot of money on stuff that doesn't work.
Right? What else? What are some high-stakes things that can happen when you don't?
You don't teach.
You get sued, perhaps? You don't get sued in education for educational malpractice. You don't. There have been a couple of cases, and it's fascinating. We should, quite honestly, we should get sued as educators when we don't do our job. There's a lot. I'm doing PowerPoints today, I wish that we didn't have PowerPoints. People abuse them. If you've ever sat through an awful lecture, you just want to sue the person, right? Like, please stop. So there's good reason to approach our teaching and learning roles with some sense of what the evidence says. These are some of the best journals. This is the Dean's Journal. And this journal right here is probably the highest impact factor. That journal, Journal of Graduate Medical Education, is all about residents, how to teach residents. And these are just 3 of a there's a number of them. But sifting through that, analyzing it, distilling it, synthesizing it, figuring out how it applies to your roles as teachers is a lot of work. It really is. And we don't make it very easy for people. So anyway, my one big idea is that hopefully you will think more often about how to apply some of the evidence to your roles as teaching. All right, so this article just came out timely in June of this year. And these guys are big in medical education over in the Netherlands. And they said, what would happen to education if we take education evidence seriously? And they cover in this article these 6 areas of evidence. And they point to a number of ways that over and over and over the research shows the importance of these areas in teaching and learning and education. And oftentimes we don't heed the advice here. But I'm going to take us through these 6 pretty quickly, hopefully. And maybe we'll see what you guys think about some of this. All right, so the first one comes from cognitive psychology. And we know that to the extent that you elaborate on new information, it sticks and it stays. So there's different ways you can do that. You can talk about it with other people. You can work on schemas. I'm speaking to neurologists, not that's intimidating to talk about schemas and neuronal connections, but really that's what learning is. When you boil it right down to the biological basis of what it is, it's neuronal connections and schemas, building on schemas, developing them. Summarizing information is a great way to learn it. Summarizing things in your own words is absolutely wonderful way to learn. We know it's hindered when people just passively consume information, like in traditional lectures. So cooperative learning, we know this really works. As you know, we have medical students here in the room, raise your hand. Sure. So you guys are doing team-based learning in your curriculum. Why? Because the evidence shows that it works. It works better than lecture. In our professional lives, so many of the things we do are done in teams. So there's a hope that as you learn in teams that you might be better when you get to the end point in your profession in working with others as a professional in teams. Feedback. This one's really, really important in clinical education. Very powerful. It's most effective when whoever's giving the feedback is credible. The focus of the feedback is on behaviors as opposed to personalities. It's helpful when a culture of feedback exists, when it's just the way that we do it around here. Dialogue and the follow-up from feedback. So when you give somebody feedback, following back up. So how'd that go? How do you find, how's that working for you now? That kind of following up is really helpful. And you got to give help and support sometimes. So there's a lot of feedback, evidence about narrative feedback, written feedback. So in 360s, in your residency program, you probably use 360s. And ideally, the people write some comments. Residents, have you gotten comments on your 360s? Do you find them helpful? Most people do. Anytime I talk to residents and fellows, they crave narrative feedback, or if not direct feedback. But there's also a lot of literature shows we don't do this very much in medical education. We're busy, right? It takes a little bit of time to do that. And we'll talk a little bit more about ways to do this better. We know that being sincere and trying to be helpful and constructive, actionable, that's very helpful, thank you. So when you're writing narrative feedback, it's helpful to look back at the goals and objectives for the particular rotation. So what are the goals and objectives for the clerkship rotation? And trying to couch the feedback in relative to those objectives. And then what do you need to do to get better? We all like to hear that. There's some specific words that you can use, and you can see them here. It's helpful. It's helpful if you can use very descriptive words in your feedback. And you can see just some areas, dimensions. These kind of comments are rarely useful. Sometimes it's hard, especially with superstars, it's hard to come up with what to say other than they're awesome, right? They're a superstar. And we don't have to work as hard with the superstars. They're going to learn on their own. We don't have to work as hard with them. They're going to learn regardless of whether we teach them anyway. So here's some ways we see these personality traits all the time in our work, in our educational work, and sometimes figuring out the nicer ways to deliver this feedback. You can see some examples here of how you can focus on the behavior in giving feedback as opposed to what might seem like a personality trait. So even some of those might be hard to deliver, right? But if folks aren't doing well, they need the feedback. They have to know. All right, so mentoring is another area. We know that mentoring is associated with increased use of feedback. It's associated with career success, higher jobs, better pay, decreased burnout. So the task of a mentor is really one of coaching, asking questions, inquiring what students want, as opposed to just giving them answers and telling them what to do. Mentees also have an important role in the mentor relationship. You really have to own it. Who in the room has a mentor or has had a mentor at some point in their career? Pretty much everybody. Who has had to seek a mentor? They didn't just come to you. You had to this is hard work. Sometimes you have to find mentors and you have to seek them out, and you really have to put the energy into crafting that relationship. You really need mentors along the way. And it's important to have a sense of psychological safety in these relationships where the learner really feels comfortable in being able to acknowledge some deficiencies that they might have, things that they know they need to work on, trying to figure out how to get there. I love these comments here, things that mentors say. I believe in you. How can I help you? Why don't you come with me? I love that one. This one, oh, I love this one. It happens to me. There's this lady named Pat O'Sullivan that she's a megastar at UCSF in medical education. She used to be here, and I actually sought her out as a mentor. I looked her up. I found her. I said, please mentor me. And she's like, I'm kind of busy. Yeah. She did. But she left, but she stayed a distant mentor. And now the only time I see her is at meetings. And when she says this to me, I'm there. I am there. And I meet all sorts of people. She connects me with all sorts of people. She helps me find books. We walk through a conference. It's amazing what can happen when you just trail along with a mentor. So anyway, those are kind of cool. Thought you might like them. Engagement. This is really, really important. How do we engage people? Well, I am going to engage you guys, and I promise this is not just going to be me talking. You're going to have to participate a little bit today. So we'll go ahead and plant the seed that there will be some engagement for you today. If you'll take a card and pass it around. If that's not enough, I have more somewhere here. So we're going to engage people in the process. It's the opposite of burnout, really. It's facilitated by a nice sense of balance between the demands and challenges in the environment and what the resources that you have to bring to, as well as your own personal resources. Teaching-centered focus in classes, programs, really is associated with a less than ideal learning climate and burnout. So when you participate in something, you're more likely to learn. If you're not using the information, it's hard to learn it. It's kind of a nice quote from Sir Richard Branson. There's no greater thing you can do with your life and your work than follow your passions in a way that serves the world and you. So we all have passions, and bringing those to work and bringing those to our teaching and learning is really helpful. So, and then the last area of evidence from this article that Dr. Dreesen wrote is that learning is done in a social context. Knowledge really is socially constructed. What is green? What is blue? These are social concepts that we have developed over time. All knowledge works that way. There's this idea called situated learning. There's a whole theory on it. Lave and Winger developed it. And it's a nice extension of the apprenticeship model that you guys get. So many people in education look to you guys with some sense of envy in that the way that you get to learn medicine really is by doing it. That's amazing. So not everybody gets that in their profession. So we have to take simulated experiences in many other professions and make them model what the profession is going to be like in the end when you're done with your school. You guys actually get to learn it in situ, and that's a great way to learn. So it comes with a lot of responsibility. So relationships and dialogue, supervision, these are great ways to learn. There's just tons and tons of evidence about it. All right, so a few questions for you. Did everybody get an index card? Do we need more in the back? We do need more. Did you guys get index cards over there? Yeah? Okay. All right, so a few questions for you guys to consider. Why do you teach the way you do now? How did you learn to teach this way? Or did you? Does the way you've been taught mirror or contradict the way you teach? All right, so there's a lot of wisdom in the room, and it's a good idea to tap it at this point. So what I want you to do is think about these ideas and think about one of your best teaching tips that you would like to share with new teachers that maybe haven't been taught a lot about teaching. So, and it can come from something you learned or just you're a good teacher. So anyway, take a minute and write down a good teaching tip that you would like to share with everyone on the front of your card. I think some wisdom exists way back here. So, we're going to walk back here and find out what you guys think. We are working on index cards and writing down teaching tips. What are teaching tips? All right, somebody from this area back here, will you be willing to share your teaching tip out loud with everyone? Yes, be real loud so everybody can hear.
So the first thing is asking the student the question first and see what he knows, what he doesn't know, and a follow-up question to go then deeper and deeper, and then asking why he gave that answer. And first, knowing what the student knows, basically. And in that process of him saying what he knows, he will reinforce what he already knows. And I have an opportunity to correct, and then probably identify new areas of knowledge, and they ask about that, and there.
This is called what? Does anybody know? There's a name for that strategy. Huh? What? Yeah, over here. That's right. It's Socratic method. Excellent. It's one of the oldest forms of teaching that there is from Socrates.
I didn't remember.
Yeah. Yeah. Well, it gives in your particular profession, it gives you a chance to figure out what the learner needs to know. There's deficits, errors in their thinking. Those are hard to fix. Errors in thinking. When you've got something wrong and it's hard to get rid of that. All right. How about from over here? Well, how about a tip from you guys? The guy that had the question right. How about you? What? You have a tip for us?
We have
Sorry, I shouldn't say the guy. Ethan.
We used to students, but I have taught a little bit before, and my big thing is teaching by action, teach by doing, and having people work problems or work through situations. That sort of thing.
Good. Problem-based learning. Problem-based learning, we have team-based learning here, but there's a lot of medical schools that have problem-based learning curriculum. And that's how they learn. I was at University of Hawaii 4 years, and their whole entire medical school curriculum is problem-based. And I got to be a tutor in that environment. These students are the most amazing thing I've ever seen. They're just on fire. They don't even have to have a teacher. They're just learning it themselves. You give them a problem, they figure it out. Brilliant. Brilliant. That will stay with you forever. It will. All right. How about up here in the wisdom zone?
So I've related this story a couple of times to the group, but when I was an early assistant professor, they asked me to give a lecture on the cranial nerves, and so I put together this beautiful PowerPoint, these wonderful images, and I thought this was so fantastic. And I went in, the lecture went way long. And the feedback I got was, this was horrible. This is the worst. And there was one comment, a very instructive comment. This professor should never be allowed to teach medical students. So what I did was I completely went back. I said, A, I need 2 hours. And B, I had a case for every cranial nerve. And the first thing I did was give the case. And then I'd ask what they thought. And then I'd say, and here's the anatomy we need to answer this question. And then we went back and we answered the case. And after that, they loved it. They thought it was great. In fact, I had students stopping me afterwards or even years later to say, I still remember that lecture. So the take-home message is case-based learning trumps standard presentation of facts every time.
Absolutely. Absolutely. Good. Anyone else up here in the wisdom zone want to share? We have two that want to share, yes?
I have two things. Number one, be a good listener. And the second is, don't try to cover all the knowledge in the universe at one time.
That's great.
Kind of relative to what you were saying.
You know, that one of the best teachers on this campus is Keith Williams. He teaches biostatistics. Has anybody had stats with Keith Williams? Is he a great teacher or what? He is a great teacher. Nobody likes to take statistics. That's why you didn't raise your hand. You're like, why would I do that? I had to do it. Actually, I enjoyed learning statistics with Dr. Williams. He is an amazing teacher. One of the things, I was trying to analyze, what is it that you do that makes you a good teacher one day? And how can I be a good teacher? And one piece of advice he gave me was just hammer the fundamentals. Hammer the fundamentals. Don't worry about the details. People will fill in the details. People will fill in the fringes and the bells and the whistles. But if you hammer the details, that's really good over and over and over, especially in y'all's profession. There's a lot of things that you need hammered, and you need a lot of practice with, some fundamentals. Don't try to cover everything in the universe. There's not enough time. Sir?
I think there's a Chinese proverb that says, I hear and I forget, I see and I remember, I do and I understand. And I think the way we should try to teach really is not to give facts, but to have our students get to those facts through some kind of personal experience or general knowledge that they have.
Yeah.
Just give, it may be a silly example, but we talk about the deposition of material in the carotid artery. Well, you can explain why the material deposits where it does by having students think about a river like the Mississippi, which has, oxbows. When the water flows on the convex side, it goes faster. When it flows on the concave side, it goes slower. And so it deposits silt, and so the river is constantly changing. Well, that's exactly where the deposition of material occurs in the carotid artery. Now, if I told them that, they could forget it. But if they go through the process saying, well, it kind of makes sense because it's really part of fluid mechanics, and we learned this in high school in physics class. So if you help them work through that, then I think those facts then gain more of a staying power in your brain because you've made some connections with a totally unrelated field.
Dr. Nazarian, am I saying that right? Nazarian just did a fabulous thing in his example that we know from research. Analogies. Simple, really simple analogies. The guy at the that runs the gas station could understand what you just said, right? Simplifying a difficult concept. Beautiful. Excellent. Anybody else want to share a tip? We're going to move on. We'll get more from others immediately. All right. So I want to talk about curriculum for just a minute. Educators think about curriculum kind of at 3 levels. So there's the formal curriculum. That's the planned curriculum. That's the goals and objectives in all of your manuals and your rotations. There's the informal curriculum. This is kind of what happens when you're walking around all day with students and residents working together. This is where learning really happens in clinical medicine. It's not in the lecture halls, really. It's in much more informal settings. Then there's what we call the hidden curriculum. And this is sort of the culture and climate. It's how things work around here. I love this quote from some power educators. They say, every word, every action, every time we choose not to speak or act, every smile, every curse, every sigh, it's a lesson in the hidden curriculum. So we are all teaching and learning all the time, whether you think about it, whether you realize it or not, just how you carry yourself, you're teaching. You're teaching medical students. They're watching you. So you're role models. We have a couple of projects. Jan Shorey, who's our Dean for Faculty Affairs, is very involved in work on the hidden curriculum. There's a couple things that happen that I want you as residents to be aware of if you don't know about it. One is that the medical students fill out a survey about you, attendings too. They fill out a survey about you every January to June. And they're rating your professionalism, what they see, not you personally. But while I was on this rotation, and there's like 12 items from the ABIM Professionalism Charter, and they're rating. Here's what I observed. We feed back that information to department chairs and deans every year. So you are being watched, and you are being assessed in this area. We're not doing it to be weird. We do it because it's an LCME requirement, quite honestly. But we also believe that it raises the value of these things. It brings to light these things are important, and these things matter, and these things are valued. So another thing we do here in a couple of clerkships, not yours, is we ask the students to journal in Blackboard about something meaningful that they observed while on a clerkship. And I want you to see, so these are the requirements. Here's the rationale, one rationale, as to why you guys as residents must be teachers. There are ACGME mandates, that it's our professional responsibility. We require residents to supervise medical students, and LCME requires that you're taught to be familiar with the learning objectives for the clerkship rotations that you're supervising students on, and that you're prepared for this role. So this is one way to prepare you. Have a grand rounds on it. This is what I wanted to get to. These are direct quotes from medical student. I need another medical student to read this for me. Medical student, volunteer. They'll read it out loud for us, please. Yes.
The residents on my service were very welcoming to all the students. They were very receptive to questions and were there to help us when we needed it. Most residents on all our rotation this year were nice. However, some seemed not to care much about the students. They would bypass us without helping, and some were even a little demeaning. On this service, every resident seemed to truly care about the well-being of each student. Not only did they want us to succeed and learn, but also to make us feel as comfortable as possible as we work together. This makes for a great learning environment and a great experience.
And so that's from our medical students right here at UAMS. And then they have some competency requirements. So they log what competencies are associated with their meaningful entry. Isn't it neat that a student journaled this as, what's the most meaningful thing that happened to you on this clerkship? Wow, I have more. I need another medical student. Thank you. Will you read this one for us?
Our resident on clinic not only did she check with each student multiple times a day to make sure we knew what was going on with our patients, she also checked with us to make sure we knew why it was going on. She went to lengths to see that we were ready for rounds, giving us an idea of what would be expected of us, as well as what we should expect from rounds. Always eager to answer questions and teach, she really made the clinic an educational and enjoyable experience.
Meaningful. The most meaningful thing this student journaled about on that rotation was this. You guys are really important as residents. I have one more example. Do we have another medical student be willing to read? Yes? Okay, this one's for you.
The residents I encountered while on this clerkship were very professional. I found them to be excellent teachers. Their primary goal was to ensure that the students were comfortable with a wide variety of patients. We were treated as members of the team.
Awesome. I love these quotes. I read these quotes. You wouldn't believe what all people write about in these quotes. I just sifted through them. Mostly what students write about are connections that they have with patients. Patients are amazing teachers for our medical students. But I sifted through them and found the ones that were about residents as teachers, a few of them. I mean, there's more. These are just a few examples. That's what's happening in the hidden curriculum. It's important. Okay, so back to this idea of being adaptable. As teachers, especially residents, you're going to have to find ways to fit it in. Not just lectures, that's not how we teach. You're modeling professional behavior all the time in your daily work rounds, procedures, in your ambulatory settings. It doesn't have to be a whole lecture. It can just be a mini lecture. It could be just a sentence, a principle, an idea, a conversation to understand what the student knows and doesn't know, to make sure that they're getting the objectives of this rotation. It takes a lot of, it's complex. This is not easy. I think it's difficult. Teaching and learning is difficult. Teaching about teaching is even more difficult. But that's another story. So anyway, kind of 3 phases to think about in your teaching, no matter what the setting, is preparing. So you have to know the goals and objectives. You've probably been briefed by the clerkship director on what the goals and objectives are for the rotations that the medical students need to be knowing. If not, then you can find those and familiarize yourself with them. From the back, you got to assess the learner's knowledge and their deficits. That's through conversations. You might ask the learners to read, encourage them to do their own self-directed learning. And communicate. We can't learn for anybody. We can't help anybody learn, really. I mean, if you don't want to learn it, you're not going to learn it. We can teach it all day long, but if you don't want to learn it, you're not passionate about, you're not going to. So anyway, communicating expectations is really helpful as well. In the teaching process, knowing people's names, Ethan, Dr. Sagan? Nazarian. Dr. Nazarian. That is a lovely name. It helps to use people's names. We like to have our names used. Thinking out loud is a really nice strategy. Who does think out loud well? Does anybody do that well when you're teaching? Anybody?
Try to.
You try to. What did you say, sir?
What was the question?
Do you do this well? Do you think out loud while you're teaching? While you're working?
Think out loud.
Think out loud.
Well, yeah. I do that.
We try, right? It's not easy. Sometimes you have to stop yourself and think about why it would be helpful, but students really appreciate this. They do. Providing opportunities to reflect. Asking learners to self-assess. How'd that go? What'd you think? There's a strategy that kind of brings some of all this together called the 1-minute preceptor. You've probably heard about this. Residents, you all got a teaching manual at orientation. This is in there. You can get to that manual, anybody. It's online at our GME website under resources. These are the steps of the 1-minute preceptor. And I'm going to show a video. It takes about 3 minutes. Three to 4 minutes. Here, how do you minimize this?
Just hit escape.
Hit escape. Thank you.
There you
See? I learned something already. This is from here at UAMS. It's new, hot off the press. This is what it looks like.
Hey, is it okay if I tell you about the patient who's in room 3?
Yeah, let's hurry up though. We gotta go to clinic.
Oh, okay. So this is a 26-year-old. She's a G2P1. She came here today because she's having a lot of pain and bleeding. She had a positive UPT, and but she's real unsure about when her last menstrual period was.
Okay.
She's not a great historian, but she did tell me that she smokes. Her grandmother had breast cancer. Her last pregnancy was a term vaginal delivery without any problems. And she told me that she does work at Sonic.
Okay.
Do you want to know her vitals?
Yeah.
Okay, so her temp was 98.6. Her heart rate, I forgot to write it down. They're retaking her blood pressure right now, and she's allergic to penicillin.
So
if you want.
so she's, how many weeks is she? What brought her into the ER? Is she hurting? Is she bleeding? Did they do blood work? Did they take any pictures? Any imaging?
Yeah, they did get an ultrasound, but they told me that they didn't see anything on it.
Okay, so what do you think it is? What's your differential?
Well, it could be a spontaneous abortion. It could be a threatened abortion. It could be a mole. It could be an ectopic. I guess she could have cervical cancer.
Look, I just need to know if we need to take this lady to the OR or not.
I mean, I don't know.
I mean, wait, what was that? Is she getting blood?
Yeah, that'll be her 4th unit that they're about to do.
Okay, hold on. Let me get So what do you think this is?
Well, most likely I think it's either an ectopic pregnancy or a spontaneous abortion.
So what are some things that would help us decide what it was?
Well, we know that her beta HCG was 2,500, and we know that on ultrasound we didn't see anything inside of her uterus.
Okay. Is there anything in her medical history that might help?
Oh, she did tell me that she did have a past history of having chlamydia.
Okay. Okay. Has she had any surgeries in the pelvis?
Oh, yeah, she had her tubes tied in the past.
Okay. So that would be pretty important for something like this. So you're doing pretty good on it so far. With her beta being higher than 2,000, you're right. We would expect to see something in the uterus at this point. And you've got the fact that she has a history of chlamydia, and she has a history of having her tubes tied. So those are all things that put her at a higher risk for an ectopic pregnancy. What's something else that we might want to know?
I'm not sure.
So the other thing we'd want to know is her blood type, because we want to know if this patient needs to receive RhoGAM or not.
Oh, okay.
So you did a really good job of gathering information and knowing her beta results and what the results of the ultrasound were. The one thing I would say, though, that's really important is the fact that you need to start off your presentation with the part where the patient's unstable. She's getting her 4th unit of blood, so that tells us that this is probably a ruptured ectopic, and this is somebody who needs to go to the operating room. So that's something that is a key fact you always want to consider.
What do y'all think about that?
That was cool.
Any other comments about that video? See, it was quick, right? It's a pretty quick idea. You can do this easily. A little bit of structuring, a little bit of practice. You guys are probably already doing it. Let's see, how do I resume? Maybe I can just go from right here. Yay, that was good. All right, so here's another example of a different area and words that you might say to sort of facilitate this idea. Like getting a commitment, probing for evidence, teaching general rules, reinforcing what they did well, and correcting any mistakes or giving feedback. Right, so a few more questions for you guys to write on your card. How do you learn best? What is learning? What is learning? I like to think of it as the biological explanation. I'm a big fan of that. But feel free to comment on your card about any of these ideas. Some sort of maybe a challenge. I want to take your cards and I'll summarize them, send them back to you, share them with you. I've often I've done this in surgery going rounds, and this particular question right here, what are some of the challenges? Very common challenges are time, motivation, and difficulty remembering. There's a lot of information. People struggle to figure out how to remember and reinforce what they're learning. I suspect that this second question right here, how do you learn best? There's probably about 35 variations on a theme there. It's a really individual process. Everybody's brain is highly unique, highly individual. What works for you isn't necessarily going to work for the next guy or girl. move us forward a little bit. We might come back to your cards and talk about them in a second. So some of the common challenges with learners that we know exist are in bold there. They might be slow, have poor knowledge and skills, maybe poor interpersonal skills, and unmotivated is really tough. They don't want to be a neurologist. They're just kind of passing through on this rotation, not really into it. What can you do with this kind of folks to motivate them? Those are difficult. But providing clear expectation, asking the students why, what their motivations are, and what is it that that your goals might be while on this rotation, and helping them achieve those during the rotation is very helpful. So who knows about the X-rays? I love this one. As in terms of being able to give feedback. When you did X, it made me feel Y, and I'd rather that you do Z. So that way you're not really criticizing the person. You're just very clearly stating the expectations. Tips, just some more tips. Okay, so back to you guys in your field. I found this article in the Neurologist 2004, The Challenges of Residents Teaching Neurology. And these are comments from resident selected best teachers. I thought you might find them interesting. These are tips from good resident teachers. Being passionate about what you're teaching, keeping the team relaxed using humor, that is a really good one. People like people that make them feel relaxed, right? We like those people. Praising publicly and correcting privately, providing lots of clinical vignettes, Greenfield. Avoid flatly rejecting a student's answer. No one knows everything. Learning is a two-way street. Make it fun or at least interesting and practical. Admitting that lack of knowledge is wise at times. Just ask the questioner to look it up and report back. Be flexible. All people learn differently and as such need different teaching methods. Some more nuggets of coolness from this article. Top 10 tips on becoming a great teacher. Be enthusiastic, even when post-call. Enthusiasm is the #1 characteristic rated by students of great clinical teachers. The #1 is enthusiasm. Letting the medical student interact with the patient. Learning by doing, right, Ethan? Being respectful of patients. Being available and present. Students should not have to find you, right? You need to be available. Making people feel useful. Not making excuses, making time to teach. Knowing when to stop teaching for the day. For heaven's sakes, there's a point in time in which nothing new can be learned, right? Being prepared. And I don't know about that last one. Always certain, mostly right? I don't know. Anyway. And then some suggestions for core topics to have a scripted talk prepared. These are for residents. I thought this was kind of neat. So if you are a resident and you're looking at this list going, I don't know what I'd say, you might want to contemplate this list a little further. Because these are things to have on hand at any given point in time in your field, apparently, to be teaching others. It's a nice article. It's a nice read if anybody wants to go through it in more detail. So I'm talking about assessment for just a minute. There's feedback. Rather informal. And then there's evaluation, which is the more formal types of assessment. One type of assessment that you can use anytime is kind of informal. I love this, by the way. Just at the end, any point where it makes sense. It could be at the end of a lecture. Dr. Greenfield learned a lot from some feedback on his lecture. But so you might ask, just grab a piece of paper, don't put your name on it. Write down what's the most important thing you learned today. Or what important questions remain unanswered. Let's say you gave a great lecture on whatever it was, and you find out they didn't even get it. What's fascinating about this particular thing is that the responses I get to this question, it's amazing, 35 variations on a theme. You will all have gotten something different out of this today. And it may not even be something I intended. So my goals and objectives that I set out to do today may not be what at all you take away from this session. Tricky thing about learning. But these are really helpful if you're trying to get some feedback on how to become a better teacher or what it is that people are actually learning. It just takes a minute, and you get instant feedback. A mid-rotation survey might not be a bad idea before things get too far gone. Some questions like this might be helpful for you to get a sense of what the students, where are they at, where are their heads at, what do they want to learn. They thought they were going to do this, that, and the other, and that hasn't happened at all. Just some ideas. You can do these easily, informally. Just grab a piece of paper, ask your students to do these kind of things. All right, so I want to leave you with the idea that please identify just one thing that you might put into practice for the rest of this semester about improving your teaching and learning. I love this picture of the network teacher. Who's on Twitter? Who does Twitter? Oh my gosh. Okay, you guys are missing like a whole world out there, just saying.
Thank heavens. They're focused on medicine.
Wow. Some of the best thought leaders in medicine are huge Twitter posters, right? Bob Wachter at UCSF, Mr. Patient Safety. The stuff he posts on there, you guys, instant. Last week, on Thursday, there was a Senate panel about patient safety. Professor of Public Health from Harvard testifying in front of Senate about patient safety, saying it's the third leading cause of death, not the eighth. The third leading cause of death in the United States. What? Patient safety issues? What? And that 800,000 people, not 98,000 people, are dying a year from patient safety errors? Guys, how'd I learn that? Twitter. Yeah, right there. Good stuff. Anyway, your professional society for neurology has wonderful resources on teaching and learning. They have this handout that has all these vetted websites on how to that are good if you want to learn about whatever the things that you learn about. They have all sorts of vetted websites in this neat handout at this website. You can teach yourself anything with Google these days. You can teach and learn anything. You just have to be driven. You have to want it. That's how learning works. You have to be passionate about it. You have to make it happen. All right, so this is the last thing I'm going to leave you with before we move on to maybe sharing a few of more of your card thoughts. So this is from Twitter. July 1, it exploded with the hashtag tips for new docs. And I just pulled some that were kind of cool and related to learning. There's a bunch more, but ones that were related to learning and ones that I'm just a little, what are you laughing at?
Ask. Be nice to the nurses. They know more than you. Right?
And ask. So rule number 1, question you decide not to ask just because you might look stupid, ask it. Just ask it. It's okay. I love number 2. Patients have a story, a life, priorities, fears, anxieties, not just pathologies. Learn about those. Always remember to say, hello, my name is. Please do this. It's really important to the patients, as is number 9. Before you leave the room, have I answered all your questions? Give them that opportunity. They need you to say these kind of things. All right, back to number 4. Set the right example to everyone you meet at work. Imagine every patient is your closest relative and treat them accordingly. We did number 5. Respect online professionalism. I don't think you guys have to worry about that if you're not on Twitter, or maybe you're not. Who knows? Who has time for that? But if you wouldn't say it to your grandmother, don't say it on a social media website, Facebook or otherwise. Have a pharmacist buddy. You'll learn lots. That one comes up over and over. You can learn something from everyone. Sometimes you will not learn how. Sometimes you'll learn how not to be and how not to do. And remember those lessons. Great, so that's what I have for you today. I appreciate your attention and your enthusiasm. Any other teaching tips or learning tips you want to share from your cards? I would love to collect your cards if you would allow me to have them, and I'll summarize them and send them back to you through Dr. Metzer. Okay?
Thanks.
Great.
Thanks. You want to just put them on the middle table, and I'll pick them up afterwards. Thank you. Have a great weekend. Very good.
For the politicians, peer review.
What's that?
That's what it's
Well, the problem is it tends to be
Nice to
voluminous.
have your input. Thank you.
And, it's like drinking out of a fire hose.
You can't do all
Thanks for having me.
that. You gotta get going.
So I've avoided it intentionally.
Some student was looking for me. Who was that?
That's me, Dr. Cole.
That's you?
Yeah.
Okay, you're not a student, you're a resident.
Resident, yeah.
Yeah, I misunderstood. Okay, what you want to do?
So, I read this article in